All right, we'll go ahead and get started. Thank you again, everyone, for coming today to our second workshop on theories, models, and frameworks in dissemination and implementation science. Just a few housekeeping items before we get started today. Restrooms are just out this door. If you turn left and left, they'll be right outside. And then the other. Just
Can folks hear us now? Okay, great. Well, thanks to everyone that traveled here in person and to folks that are joining us on Zoom today. We have a workshop around theories, models, and frameworks. And let me tell you, I think we could probably have 6 to 8 weeks of sessions just on theories, models, and frameworks. So this is much like our previous workshop, a little bit of an introduction, hopefully to get you some hands-on opportunities to think about how you might apply theories, models, and frameworks to your dissemination and implementation science work. And so to give a little bit of a, let's see if I can get this to move forward. There we go. A little bit of a reminder, this is the definition that I think that was used in our last workshop as well of what dissemination and implementation science is. And so by definition, it's the scientific study of the strategies and mechanisms by which scientific evidence is disseminated and implemented in community or clinical settings to improve outcomes for a specified population. Okay, so that's kind of where we start. The first question I have for folks here, and hopefully people online can hear this as well, but what do people think of when you think of scientific evidence?
Peer-reviewed journals.
Peer-reviewed journals. Okay, so things that we might get, this is when we think about evidence-based interventions. How many people have heard that term before? All of us, right? So some of the things that we're going to go through, there's a number of different ways to determine whether something has enough scientific evidence to be considered an evidence-based intervention. I've got some of the bullet points up here. At one point, NCI had this 5 levels that they talked about for evidence. And today I'm going to use a couple of evidence-based intervention examples. One will be building healthy families, which is a family healthy weight program that has demonstrated effectiveness and sustained reductions in child and parent weight status for overweight and obese children between the ages of about 6 to 16. The other one that we're going to talk about, and this one we're going to use, the second part of the workshop is going to be primarily an activity that we've developed to help people think through how they're applying theory to a certain context, the strategies that they're going to use, and the mechanism by which those strategies work. And so this one is called Weigh and Win. It's a community-based weight loss intervention that was delivered primarily through digital technologies in a package form that is used in work sites as well. And so we're going to talk about it in our example from work sites. Okay, so the next thing that I always think about is really what is dissemination and implementation science all about? And I'm going to give people a chance to answer that question. What is it all about? JD, what is dissemination and implementation science all about?
I'm trying to get best available research knowledge.
Okay, so JD's response was trying to get the best available evidence into regular or sustained practice. Anybody else want to try and top JD Smith on that one? Okay, well, I'll go through what I think it's all about. And I think this is really when we try and work with folks that come into the DIS core, which are Dissemination and Implementation Science core with the CTSI for consultation. This is kind of where I start with folks, is that really dissemination and implementation science is about documenting the relationships between strategies, mechanisms, and outcomes to produce generalizable knowledge, right? So it's a scientific field of study. And within this scientific field of study, we really use theories, models, and frameworks a lot to understand the context that's related to the evidence-based intervention, dissemination, or adoption, implementation, and maintenance. Okay, so these are things that I think are fundamental to dissemination and implementation science. We also primarily design strategies that improve evidence-based intervention, adoption, implementation, and sustainability. that fit within a given context. Okay, so a lot of our work on strategies is trying to figure out what type of strategies will fit within a given context to produce the outcomes that we're hoping for it to produce. And then finally, you'll see again, we come up with this area where we're looking at the use of theories, models, and frameworks to identify the mechanisms by which strategies achieve outcomes. And to me, this is really the fundamental generalizable knowledge that we're trying to identify, right? We have a strategy, it works to change the adoption or uptake of an intervention, and we understand the process by which that occurs. And so that if we want to change the strategy out, we know what the mechanism is that we should be targeting. And it might be that we need different strategies to target the same mechanism over time. Okay, so the next thing I wanted to just do a very, very brief overview of, we're going to do our whole next workshop on this, but what are dissemination implementation outcomes? Anybody want to take a shot?
Could be the rate of uptake of like adoption of a particular strategy.
Great. So one is the rate of adoption of a particular evidence-based intervention. I won't pull teeth on this one. I'll just kind of go through. Oh, okay, good. In the room, we all of a sudden lost the screen, which makes everyone panic. Up here, you can see there's a couple of frameworks that are used a lot across dissemination implementation science. The REAIM framework, which was one that I've worked with for a long time, and we still continue to develop and update. The other is the Proctor Implementations Outcome Framework. And when we come together next time, we will focus a lot on how some of the work that we've done to integrate those two models to help them make sense both in healthcare and community settings. And one thing that I didn't give much of an intro to for folks that are here, most of my work is in community settings. I still do some clinical stuff, but primarily in community settings. And we've used REAIM a lot because it's a very intuitive model for communities to understand. You know, it's about reaching people that could benefit from your intervention, having an effect with those people, maintaining that effect. And then it's about adopting, implementing, and maintaining an evidence-based intervention. And so it's a very intuitive way for folks to pick up the idea that there's multiple outcomes that we should be concerned about when we're trying to take something to scale. Okay, so the other thing I wanted to give a little highlight of, and hopefully folks that came to JD Smith and Jenny Hill's workshop last time remember all of this stuff too, because they gave a quick overview. But we also focus a lot on this idea of strategies. And don't worry, I'm not going to list up the 73 ERIC strategies. We will have a workshop that will go over strategies, but this is a kind of a clustering of topical buckets of the different types of strategies that we might want to apply to improve the adoption, implementation, sustainment, reach of an evidence-based intervention. And so for this one, I wanted to just give you a quick example. Again, we're going to talk about building healthy families. I'm not going to give the pilot hybrid type 3 effectiveness implementation study that Jenny Hill, myself, and some other folks did. That is really underpins all this. I'm just going to give you some snippets of the study. And so in this particular study, we took that Family Healthy Weight program, Building Healthy Families, and we applied two primary strategies. One of them was that we took, and this was for rural communities. And so one of the things that we did is we took all of the training that was needed, all of the materials that a community would need. We had fidelity assessments, and then we had a data portal, all combined into one online resource and training package that a community could just press start here and be trained to develop the capacity to deliver the program locally. Okay, so package the program up. And so when you look up here, some of the categories of strategies that are included in there are to train and educate the community, to evaluate and iterate using their data portal and regular reviews of the participant outcomes. And then there's infrastructure changes. Just having this online resource provides a new data infrastructure for many communities that they typically don't have at their fingertips. And then the second implementation strategy was an action learning collaborative. How many people have heard of learning collaboratives before? Raise your hands. Okay, lots of people. How many people in the room have heard of plan, do, study, act cycles? Okay, usually what an action learning collaborative does is it integrates a number of plan, do, study, act cycles that focus on reach, adoption, implementation, sustainment of an evidence-based intervention. And in this particular case, it focused on bringing communities together that were different communities together that were all trying to deliver the same family healthy weight program in their rural communities. And within there, they come up with strategies, peer learning, sharing, and Jenny could give you a much better description of everything that's in there. But these are the two primary strategies. So some of the communities got just the package. Some of the communities got the package plus participation in the action learning collaborative. Okay, and so then the last thing that I had on there was this idea of context. And so we look at our theories, models, and frameworks to give us a sense of context. Who can tell me what context is? I bet James Merle could take a shot at it.
The place where you're trying to implement.
Okay, so it could be the place, the setting within which you're trying to deliver an evidence-based intervention or get it adopted. There's actually a good number of definitions of context out there. And, you know, I think this is still an area within our field that we can work to understand. When I think about context, I really think about, as James said, the setting, the kind of environment around which we're trying to get evidence-based interventions taken to scale and sustained while maintaining their effect. But it's typically not the things that we're trying to change. It's things that are in that setting that we're trying to align our strategies with, and they may moderate some of our outcomes. But usually if it's something that we're trying to change, then I start to move that more towards what we'll talk about next, which is the mechanistic pathway or the mechanisms. But it can get a little bit confusing on that. And so I'll just jump right to mechanisms. How have people used the term mechanism? Is that a familiar term to folks? Okay. So I got a couple of folks shaking heads and a couple of folks, and a few more people nodding their heads. Mechanisms are also defined a number of different ways in dissemination implementation science. These are ones that I like. I like each of these definitions. One of the things that you will get throughout this workshop is an understanding that a lot of the decisions around what you're going to use for a theory within your work is going to be based upon the context, your partners, the type of study that you do, what outcome you're looking at. And so I think that it's okay as long as you lean into how, you know, make sure that you have some foundation for how you're using those descriptions. One of the areas that I know people are a little bit contentious about around mechanisms right now is talking about mechanisms as mediators. And so some folks really like that idea. Most of folks like me that come from more of a social science background and are familiar with how we would statistically test mediators. But in fact, a lot of times we can't statistically test the mechanisms, and you need to assess mechanisms through both quantitative, qualitative approaches and typically mixed methods. So these are ways that you can define them. So we are now, how many minutes in? We're 17 minutes into the workshop. And you guys say, I thought this session was about theories, models, and frameworks. And then somebody else put in the swear word symbols at the end. And so it is. And I really like this review of theories, models, and frameworks that Per Nilsson did. It's 10 years ago now, which is crazy. But what Per did was that they took all the theories, models, and frameworks, and they tried to categorize them and talk about different types. And so if you look up here, the first type is a process model. And a process model is something like what we use, an integrated practice partnership model that has kind of a step-by-step of how you would do the process of identification of an evidence-based intervention, identification of strategies, how you'd then look to see how you might need to adapt those things within your given context. Then you would do some level of integration trials, and then based upon outcomes, and we use typically REAIM outcomes, make decisions as to whether this is the translational solution for that particular system, and then it just continues on, or if it's not quite working and you've got to work back up through. So a process model really kind of gives you these steps, right? How do I do this stuff? We're not going to talk a lot about process models today. Then we have the outcome models. And so a lot of outcome models are out there. REAIM is the one, again, that we use a lot. And, you know, the distinction between, sometimes people say, oh, my theoretical approach is REAIM, which always makes everybody that's used REAIM and has worked with it cringe a little bit, because really it just gives the outcomes. It is a planning model. It can help you to plan because it gives you outcomes to try and plan through, but it doesn't give you any sense of context or the mechanisms by which strategies might work to achieve those outcomes. And if you're interested, and we will talk a little bit about the PRISM model, which takes REAIM and then puts context and mechanisms around it. And there we go. And so then the last type, and this is really what we're focusing on today, are more of our explanatory theories. So theories that give you a sense of the how and why a strategy may work in a given context. And so for this one up here, how many people have heard of the practical, robust implementation and sustainability model? Okay, we're getting about half the folks in the room here, not sure online, but this is a model that really focused on, you know, what are the things around REAIM outcomes that are either moderating or mechanistic towards changes in those outcomes as a result of given strategies. Okay, I always like to think when we start with these explanatory models of this one, I was going to ask people if they knew what it was from the figure, but then of course I see that I also labeled it. So how many people have heard of diffusions of innovations theory? Great. We got some good penetration with that one here. So this is probably the most frequently used dissemination and implementation framework because it's used across a lot of different fields. It's not only used within dissemination and implementation science. And one thing I'm not going to get into, or we're not going to get into a lot today, are different theories for dissemination and different theories for implementation, and some theories that blend those two things together. And I think if you're someone that's doing work on reach and adoption and a little bit less on the implementation component or sustainment component of your intervention, I still think diffusion of innovations is one of the best theoretical approaches to use. It's really, when we start to go through the next couple, you'll see that the foundations of all of our explanatory theories in dissemination implementation science can be traced back to diffusions of innovations. And you know, one interesting thing that I think a lot of times people don't know is that when you think about diffusion of innovations, you think about passive, right, diffusion. But actually Rogers, the developer of this model, defined both active and passive diffusion. So when he talks about active diffusion, he was referring to dissemination. A lot of the work, when you look up here, you see it has a focus on the innovation. And so the innovation is typically our evidence-based intervention. Then it has a focus on a social system and how that innovation spreads through that social system. And it refers explicitly to the communication channels that are involved to help the spread of the innovation through the social system. And then it has a component of time. And so some folks may be familiar with the S-shaped curve of when something is successful in being diffused or disseminated, that it starts off slow and then you get the pickup as people start to see its value, and there's some certain characteristics of innovations that will lead to higher uptake versus lower uptake. But in a really good diffusion or dissemination, you see a slow uptake, but then a very steep upturn and then a plateauing off at the top. And so again, I'm going to come back to this just a little bit, but I think if you are thinking primarily about uptake of things, if you're primarily thinking about reach, this is still a great way to go. A lot of the literature out there that focuses on social network analysis really comes from this perspective. And I think that folks that are using this model still really are leading the way around that type of analysis. Okay. The next one, I'm only going to touch on this one a little bit because when we do our activity for the second half of the workshop, and we have a version of that for the online folks and a version of that for folks in the room, we're going to use the PRISM framework, or the PRISM. I guess we're going to use PRISM because it has model in its name. So being a little redundant there. But when you look here, really they talk about PRISM contextual factors. And so you see multi-leveled, multi-sectoral perspectives of the intervention. So that construct is really, that is derived from innovation when we thought back to the diffusions of innovations model. And then when you look at the external environment, as well as the implementation and sustainability infrastructure, that's really more of a defined conceptualization of the social system. And one of the things that we find when you move from dissemination types of work more towards implementation types of work, you start to need to understand a lot more about the inner context and how things work for people, not only to make the decision and start using an intervention, but then using it in a way that adheres to the underlying concepts or structure. Okay. And then I'm going to move on to the next one. This one I'm not going to talk about barely at all, but I always feel like we should introduce it. Again, I would just encourage folks to look through the constructs of the consolidated framework for implementation research, and you really can see how it's expanded from that diffusions of innovation. And so the reason I kind of beat that drum a bit is that I think that diffusions of innovation is fundamental reading for anybody that's in this field, because I think that there's a lot of clarity around it. It's not quite as complex as some of our theories that you ultimately will use, but it really provides you with a great foundation for basically the overarching concepts that you're going to encounter doing this type of work. And then the next one that I am going to talk a little bit about is the IPARIS framework, which is the Integrated Promoting Action on Research in Health Services. How many people have heard of this one? Great. So we have a little bit of recognition of that here. And I'm going to, oh, that's good. I just got my alarm that I'm halfway through. Keep that.
You're right on time.
I think I am pretty close to on time, yeah, which is very unusual for me. So, so with this one, it really has 4 primary constructs. It has the innovation, which we've seen before. It has recipients. And in the original conceptualization of the Paris framework, which came before the IPARIS framework, the idea was just, we didn't have this concept of recipients, of people that would actually do the implementation. And so this is the new piece, if you were wanting to compare and contrast between those theories. And then it focuses on context. And then the key to the IPARIS framework is that it thinks of facilitation as the primary process, and it describes sometimes the mechanism by which strategies lead to improved implementation fidelity, or as they would define it, successful implementation. And so, oh, you guys can't see. You can't see it. Oh, maybe it's not on this one. I did want to give a shout out to one of our great doctoral students in health and kinesiology. Let's see, you can see her name here, Yuhuan Ji. She put these IPARIS slides together in a class we did last semester on theories, models, and frameworks, and she did such a nice job that I pulled some of those slides in and wanted to give her credit for it. I'm not sure if she's on today or not. But when we think about IPARIS, really one of the things that is attractive to me about this theory is that it has a little bit broader perspective of evidence. So it doesn't just think about the evidence that we see in the research world, but it aligns a little bit more with folks like me who are participatory researchers and understand that there is also practice and community evidence that may not be documented and tracked the same way that we track it, But if we can integrate those two things together, we're likely to come up with products and processes that are going to be much more likely to be generalized and scaled up and be able to be used across other settings that are similar to the ones that we're testing it in. The next thing is about the recipients. Recipients is a really interesting term in dissemination implementation science. And I think a lot of times what we think about when you hear the term recipient is the person that's benefiting from the evidence-based intervention. Typically in dissemination implementation science theories, the recipient is the person that's receiving the implementation strategy. So it's usually the folks that are going to be delivering the evidence-based intervention. But within IPARIS, they do talk about recipients at both the level of implementation and the level of reach. And so you could have both of those things involved there. You saw their kind of spinning wheel figure. They really think about this as multi-level. And so you'll see that they separate inner context into the local context and then organizational context. And that really, the thing I like about that is that it allows us to think about evidence-based interventions that may be delivered by multiple groups within a given community. And by doing that together, they end up having the assets available in particular and under resource settings to be able to deliver an intervention in a high fidelity way, high fidelity to principles, and achieve similar outcomes. Again, I already talked about this a little bit, that active facilitation, having people that in some of our other theories, they're described as brokers, people that can say, hey, here's the evidence-based intervention. I really understand this well. Here's your organization. You help me understand it well. And I help to facilitate how we get connections for who needs to do what, where, when, and how. And then that's really the key to getting successful implementation. And then finally, and I think this kind of goes across the board here, this integrated approach. And since I started by showing you a process model that's integrated research practice partnerships, you should probably already know that this is a very attractive thing to me, that we are looking at things that integrate both the scientific system as well as the practice system and the community system. Okay, so I'll give you a little bit in definitions. I'm not going to spend a ton of time here, but by definition, the innovation in the IPARIS framework is defined as different forms of knowledge or evidence that will be implemented. And then they have different characteristics. And so again, a lot of these come from diffusions of innovations. Is it clear? Is it usable? Is it compatible with existing practices within a system? Does it have a relative advantage over what's already being done? Is it trialable? Who knows what trialable means? Okay, tell us what it means, Mickey.
You have like the ability to try something, and then if it doesn't work, you have like the ability to take it back and try again.
Yeah. So if for those who didn't hear it, it's innovation that gives you the ability to kind of test it out a little bit. And then if it doesn't work, you back out, you try it again, you kind of go back and forth. So usually a trialable intervention also has a pretty good relationship with the complexity of the intervention, right? It's usually lower complexity interventions are more trialable, right? Because it's just a little easier to pull things in and out. If it's more complex, has a lot of different tentacles that reach into an organization, that's a lot harder to just test it out a little bit here. When we think about the way that we do pilot studies, you hear about folks that, hey, if you're doing, and there's a lot of folks that think about scalability as we're going to start it in this one clinic, and then we're going to move it to the region, then we're going to move it to the national organization. That really is an operationalization of trialability. And some interventions are much easier to do in just the one place and try it out. Some interventions are harder. Okay, and so you could see how recipient, organizational, community perceptions across each of these characteristics could lead to the adoption of an intervention. And then ultimately, even the degree to which it's delivered as intended, or its implementation. Okay, the next thing is the recipient. And again, I've talked about this one a little bit, individuals and teams affected by or involved in the implementation process. We think about these folks again in terms of their characteristics and perceptions. So I don't know if you remember back to the PRISM framework, it had these multi-level perceptions of the folks that might deliver, the folks that might make decisions around who delivers, the organization itself. All of those can have characteristics like their motivation, their self-efficacy, their skills, their knowledge, those types of things. And they can also have perceptions related to intervention. So the recipient here within IPARIS really focuses on what's the characteristics. And so you can see here, I'm wanting to kind of cue your thought back to mechanisms. These are things when we think about, kind of training approaches, it's very easy to see how the mechanisms for training approaches to successful implementation work through things like motivation, improve readiness to change. I improve the skills and the knowledge of the folks that are there. I improve their attitudes and beliefs about the intervention. All of those things can contribute to adoption and implementation. Then we get to the context, and here I talked about this a little bit already too. It's the environment where the implementation occurs. So this was, I think that's exactly the definition that James gave, including inner, and again, this breaks it up into local and organizational and outer national policies, regulations, external partnerships, as all contextual factors. And so you can see in here, this is where we get into things like leadership, communication channels, the resources and infrastructure that are within a given implementation setting, and the things that are outside of it that could influence that setting. Then we move on to the last construct, which is facilitation, defined as tailoring implementation strategies to a specific setting, to specific settings and needs. And so this is one, and I'm super excited when we're going to get to one of our workshops on specification of implementation strategies. I'm pretty sure James is going to walk us through that stuff. But one of the things here is that I find really interesting for us is that we can think about implementation strategies at a very microscopic level. We can break them down to each individual of those 73 ERIC strategies. But a lot of our strategies, and the IPARIS framework in particular, would say that facilitation itself is an overarching strategy that ultimately ends up being a bundled strategy, because it identifies a lot of different things that can fit within the specific context and address the needs that are in that context. Okay. One thing that we also are not going to talk about, and I don't know, JD, if we have this on our radar for workshops, but one of the things that I find when folks come to ask us to consult around a project is they say, well, how do I measure X? And a lot of dissemination implementation science theories are relatively new and don't necessarily have specified quantitative metrics or measures for their theories. And so that can be a real challenge. And frankly, one of the reasons that we use IPARIS a lot is that they have the organizational readiness for change assessment tool that assesses all but the recipient construct, right? Because it started when it was the Paris framework. And so it's a validated measure, and it allows us to get some quantitative assessments of each of these constructs. It's also the implementation climate scale has been used for this particular model. And then what I love about, there's the IPARIS qualitative code book. I'm pretty sure CIFR has one as well. PRISM has a qualitative code book where they provide you with really good tools where you can try and assess these constructs through interactions with the recipients and people within the systems that are trying to do the implementation and get a sense of how these things are working. And so when you go through here, the other thing that IPARIS has, which I really like, is they call it MyParis, which I thought was a really kind of a cute label for it. But they have this facilitation planning tool. And so we'll make all of the slides available and stuff. I know you probably can't tell here, but that's hyperlinked. So if anybody wanted to go and check that out, they could go and check that out. Okay. So now I'm going to get you back to this idea of, oh, you can't see at the top, but
If you push the OK button.
I don't know how to get to it from this. It's not on my screen here. So you're probably not surprised to know that the two boxes under there would be strategy and mechanisms. Okay, so we have a column here at the top that's context, then we have strategy, mechanism, and outcome. And so I'm going to start with an outcome. So remember, we talked about that Building Healthy Families project. And so this is the conceptualization of that project and how we applied theory. This is a very reductionistic look at it, but it's a method that I found that is really good in both grant applications and when just communicating with partners on what is it that we're trying to do and why do we think it's going to work. Okay. So if we want to see adoption of building healthy families in rural communities and small towns, that's the type of settings that the intervention was designed for. What are the context? What's the context around that? And so we can go back and I pulled Paris constructs so that you can see what the construct is here. So here we have an external contextual factor that within a lot of rural communities, how many people know what community health improvement plans are? Something that's facilitated typically through public health and clinical partners to identify what are the priorities within a given region. When we started this study, obesity was on almost every community health improvement plan. And so that's not really necessarily about the organization that's going to deliver it, but it's definitely an external driver. And so if we want good adoption of building healthy families, one of the things that I always look for in our work is the pull from whoever is going to use that intervention. So can we find somewhere that has a priority that aligns with what this intervention gives, right? And so then we have different types of strategies, because just knowing that doesn't necessarily help us a lot. And so for this particular one, oh, sorry, pressing the wrong button. What we identified was a fund and contact strategy. And so this would be, and now I'm going back to that list of strategies. I showed you those categories. So for this one, we gave a modest financial incentive to communities for startup. Like, what are the things, what's enough incentive to get you over the hump of, yeah, it's our priority, but it's also, there's some work here. And so a modest financial incentive, and it was like $5,000 for a community, and access to the Building Healthy Families online platform that I talked about earlier. And so we have a fund and contract strategy that's basically, you know, we all know this better as a research funding announcement, right? We request for proposals. We sent that out broadly over Nebraska where we were doing this particular project at the time. And we demonstrated that it improved adoption. And so then the question is, why do you think it improved adoption? Anybody want to take a shot at it? That's kind of a hard question. So I'll just kind of throw it out there. We propose that it work through the inner local context. And one of the big things we did with our request for proposals is that we required communities to have a partner that would focus on reach and populating the program, and one organization that would focus on delivery. And so by doing that, we facilitated community organizations within that local context to talk to one another, to collaborate, to develop the efficacy between one another. So a collective efficacy to be able to deliver the program. And our hypothesis is that's what led to the increased adoption as a result of that. Okay, does that make sense to folks? And so I want to just kind of back us up again. We're using one theory and we're walking through this idea. What's the context? How are we going to fit a strategy into the context to get a specific outcome? And then why do we think that strategy worked? And really this type of model is theoretically, it's a theoretical context, strategy, mechanism, outcome. You can take any theory and apply it to this process and use the theory really to focus on what's the context within which we're trying to fit our strategy and what's the mechanism by which that strategy works. Okay, so that's what the point I'm trying to move us along with here. So let's go to the next thing. So reach. So we want to increase participation in particular of low-income families in these rural communities. That was our primary goal with the project. And so the context here is, again, we think about the inter-organizational context, that there's a lot of variability in the organizations that you find in small towns and rural communities, right? You might have in some communities, there is a clinic. In some communities, that clinic might be 2 hours away. In some communities, there might be a cooperative extension office. In other communities, that might not be there. In some communities, there might be a grocery store that has a dietitian. In other communities, there might be a community center. And one of the things that we wanted to do is if we were gonna, I'm one ahead of myself, sorry, I'm on my next one. Within these communities, sorry, there's variability in the different types of organizations. I think it still fits here, different types of organizations and how they identify and interact with people that could benefit from participation. And so the strategy that we developed for this one was an adaptation and tailoring to context of the strategy, right? So here in that Building Healthy Families package that we created a recruitment portal. The recruitment portal wasn't in the original one. That came through our Action Learning Collaborative. Every community had a hell of a time getting people to join the program. And mostly what it was about was just getting exposure to the population that could benefit. And so we created this recruitment module that had a menu of options. If you had a clinic, there was all the resources available to help you. How do I make contact and work and partner with the clinic? What it had forms for letters that could go up from families. It had information about how you might follow up. It had, person first language, things that really helped the clinic to be able to take everything. They could take the documents and just adapt them for their local place and run with them. Other things we talked about were schools. And so within the module, we talked about opportunities if you have schools and you're in a state. At the time in Nebraska, we didn't have this, but in many states, schools and school nurses still will do heights and weights, and they will report that information back to families. So if you have that type of school in your area, we had resources for how you engage with the school and then how you could integrate the work to recruit participants into that ongoing system that the schools had. And then we had things related to, as you would expect, social media, local print, how you'd even do word of mouth. So they had a whole menu of options. And the idea here is that we fit this strategy to small towns and rural communities where we know the communication channels are going to be different from one to the next, right? And so by doing that, this one's not a big wow. The mechanism was that the recipients, in terms of the families that could benefit, they have better awareness of the program. And by providing the tools to help interface with those families, we get engagement with them, which then hopefully will lead to better enrollment. Okay. And again, you can kind of see across here, we have the inner context, and we have adapt and tailor strategy. We go, the mechanism is at the recipient participant level, and then our outcome is reach. Okay, implementation. So most people here and the folks that I've worked with in this room have primarily been focused on implementation. How do we have a specific thing and we just feel like we're not getting it delivered in the way that it should be delivered, or we're worried that we won't get it delivered in the way that it should be delivered. And so again, now this is what I talked about like 90 seconds ago. In small towns and rural communities, in addition to that variability in communication channels, they have a lot of variability in the types of organizations that would be available to deliver the intervention. And within there, people that have different levels of expertise. And so you might have, as I said, in one community, a registered dietitian from a grocery store that could deliver the intervention. That level of expertise in terms of understanding healthy eating, physical activity, and behavior change is going to be very different than if your person that's delivering it is a cooperative extension agent that's focused primarily on how we have good connections and partnerships with our agricultural folks in our community. Or it could be someone at a community center that runs the family programming that might have really good expertise around how you work with families, but no expertise as it relates to healthy eating and physical activity. So we have all these different types and levels of folks that could be in a community, as well as from different places. So a grocery store might have the person, but it probably doesn't have the space to deliver this type of program, right? And so thinking through all of those different things, this is where we came up with the idea for having the online package program that would include everything that you needed to deliver the program, everything you needed to train people. And we also built into it knowledge checks to make sure that people couldn't go out into the community and deliver content before we felt like they had the capacity and competence to be able to do that. So if you think through this one, there's a whole bunch of stuff within that online package, right? Just in and of itself. And so you would expect that it's going to work through a lot of different mechanisms. And in fact, these are the things that we hypothesized. And I have a little bit of data that I'll show you at the end here around the recipient. You know, we felt like it would improve knowledge, capacity, implementation, efficacy. And we felt like the perceptions of the innovation for the people that were involved in delivery would improve around things like relative advantage, complexity, feeling like it was not very complex and easier to implement because of having access to that online resource. And then obviously that they would build confidence to do that. Okay, so the last thing and this is all in one project. And so, you know, I want to remind you that really the thing that we're testing in a hybrid type 3 effectiveness implementation study, what's the primary outcome in that? Go ahead, Dr. Smith, you can. An implementation outcome, right? So in this case, in this particular study, implementation fidelity was the primary outcome of the study. And if you think back, I told you we had the package program, the online resource, and we had the action learning collaborative. And so everything you see up here are things that we need to be thinking about, even when we're only focused on the distinction between 2 strategies and 1 outcome. We still need to think about how we're going to get communities to do this kind of stuff. And we don't like all of these things until I got to this row around implementation and the row around maintenance are not compared between 2 conditions, but they're things that we definitely need to still have strategies in place for, because if our partners can't get people in the door, they can't reach people, we can't test how well they're going to be able to implement the program, right? And so all of this stuff is critical to think through. And this is where, when we get to the outcomes next time, we'll talk about why it's important to have an independent variable that looks at mechanisms through a theoretical approach to change an outcome, but that we can think about the outcomes that we're trying to manipulate from an experimental perspective, but then we also need to think about how we're addressing other outcomes that are going to be important for us even to have the foundation to do that testing. Okay. So that's the reason that I'm walking through all of these levels and not just giving you the implementation level.
When you're looking, when your primary outcome is fidelity, are you having do you have an a priori kind of sample size calculation for how do you actually work the sample size calculation and figuring out whether or not do you look at statistical significance in some way?
Yeah. And so remember, this one was a pilot. So we had 7 communities, which was not enough really to look between them at an implementation level for statistical difference. Although we did find statistical difference, we're a little worried because of the sample size around it. But in our larger trial, yes. And so the first question was about how do you assess the fidelity? And for this, we trained local direct observers who were not part of the implementation team. And we had them go and we had fidelity checklists that we had developed for the study for them to complete. And so that was part of our primary outcome. And what we basically looked at was the degree to which the objectives within a given session were achieved. And then we took the product of that and the number of sessions that were delivered, and that was our primary outcome. And so then we tested that, and for the RO1 that Dr. Hill just last year got a 6th percentile on. So hopefully we're going to be able to do that. We used those data to create this sample size calculation. And we'll do statistical evaluation, but for that one, we need 30 communities. So it's the sample size. Okay, so the last one I'm going to go through relatively quickly because you guys all heard my alarm go off too. The last one that I wanted to focus on was this idea of the again, the variability around the local context and expertise of the staff. You know, we have one strategy for that, but we have another strategy that also matches that particular context, and that's the Action Learning Collaborative. And you can see the labeling once again that it's a whole bunch of different strategies that are bundled within what we would call the overarching strategy, which is the Action Learning Collaborative. And again, I won't go over it in a lot of detail because I have a little bit of pilot data to share with you at the end. But hopefully you can get a sense of the distinction that we thought from the Action Learning Collaborative and just the program, the package only group, was that we would see differences in kind of this idea of relative advantage and compatibility, that by working with other organizations around this, people would get better ideas for how to make the program compatible in their local area. And by doing so, feel like this was a better approach to childhood obesity than they've had previously within their community. And we thought that by doing that, we would get improved maintenance. So not just delivering one cohort. No worries. Okay, so I'm gonna just, I think I'm actually gonna skip the outcomes, but they're really, Dr. Hill had, and her team that I am on had some really good outcomes from this. You can see that when you looked at the Action Learning Collaborative, we did have differences in implementation fidelity. Again, this one we didn't, like I said, we've done statistical tests on it, but we prefer for the pilot just to present out on the descriptives. But you can see that the number of sessions delivered, the fidelity for objectives and the fidelity for activities, pretty good differences between the two. However, any folks who have done community innovations or community interventions knows that 72 and 73% fidelity is also really good, right? So we felt pretty good about those outcomes when we compared between the resource only and the resources plus the Action Learning Collaborative. Then the next thing we looked at were the reach and effectiveness. And here's where you can start to see that, I don't know if I mentioned it, but they had 7 cohorts. And so across 7 cohorts, you can see we only had 26 families. So if you think about that, the reach really was a struggle for every community. And that's really what made us start to develop that recruitment module that we'll test in the next trial as well. But the really interesting things here is that when we looked at, we think of reach as a temporal variable. And so attendance at sessions we would consider as being a reach outcome. And you can see again, the Learning Collaborative, and we're not sure on the mechanism of this, but that Learning Collaborative, they got great attendance at their classes. Like 94% is just unreal, really. And then when we looked at building healthy family resources, again, 73% attendance in rural communities getting to a program over, a weekly program over 12 weeks, pretty darn good. But the really interesting thing here is that we saw differences in the outcome. And so BMI-Z score, for those who don't know, is an indicator of child weight status. Anything over 0 is typically good because we're stopping the progression. Anything over 0.1 is considered likely clinically meaningful. And so when you look here, the implementation strategy, so everyone was delivering the same program, but the implementation strategy also influenced the outcome, right? So with the Learning Collaborative, they got a BMI-Z change of about 0.15 and about 0.09 for the resources only. But again, this shows us that another one of the things that we're not going to talk a lot about today, but we can talk about is implementation fidelity as a mechanism for effectiveness, which is not rocket science, right? We've talked about this dose response idea a lot, but you could have dose high fidelity implementation within dose is likely to lead to better effectiveness outcomes. Let's see, this is just after our first cohorts. We now have all communities have done a second cohort, and about 5 of the 7 communities are initiating a third cohort of families. And this is after the study's done. So the study finished up funding finishes up now, but the study finished up about a year ago. And we didn't really see big differences, which is good. You know, again, with 4 and 3 communities between the two, it's hard to see much difference. And the 2 communities that aren't continuing or don't seem to be continuing are 1 in each of the conditions. Okay. And then just to give you a little bit of a taste of mechanistic assessment, we followed all of those community implementation teams for a year. We did assessments from it, and we have a bunch of other data, but these are the ones that, as you might expect, are probably the best reflection of our hypotheses. But what happened is all community recipients, so all the people that were delivering the intervention across those 7 community teams, felt that the Building Healthy Families program itself had high relative advantage and compatibility right from the get-go. But by participating in that action learning collaborative, those community implementation teams maintained those high perceptions, and in fact, a slight trend in increase in compatibility over the 12 months of delivery, while those that didn't have that learning collaborative and opportunity to engage with other folks that were delivering the same intervention didn't maintain those perceptions. And so again, we can't directly test for mediation here, especially with 7 communities and 7 community implementation teams, but it gives us a good sense that in fact, this implementation strategy likely is working through the concepts of the perceptions of the implementation teams and the relationship to relative advantage over things they've done previously and the compatibility of the program within their community. Okay, and I went like 5 minutes over. Okay, well, thank you. I'm going to turn it over to Liz, and she is going to walk through our next year.
Thanks, Paul. So there's going to be a lot of overlap between what Paul talked about and what I'm going to spend the next little bit talking about. So you heard about the IPARIS framework, and we're going to shift over and focus more on context, and I'll be talking about the Consolidated Framework for Implementation Research, or CFIR. How many of you have heard of CFIR? So a lot. Good. Okay. So we'll go a little bit more in depth and then look at an example of how you can go about assessing barriers and facilitators to inform the determinants of your setting. So just a little bit of background. CFIR originally was published by Dan Schroeder and colleagues in 2009. It emerged from a VA query project, and it is a determinants framework, which means that it looks specifically at factors that are believed to or empirically have been shown to influence implementation outcomes. So again, you think about when Paul talked about context and linked that to the implementation outcomes, we're focusing on how to assess those contextual factors. The goal of CFIR is to be able to predict or explain barriers and facilitators to implementation of an evidence-based practice. So basically what helps implementation or supports implementation, or what hinders implementation. So the original CFIR and the updated CFIR, which I'll get to in a second, has 5 domains. And basically what Dan Schroeder and colleagues did was they looked across many different frameworks in implementation and consolidated the key contextual factors into 5 domains. And the 5 domains are listed here. Characteristics of the individuals involved in implementation, intervention characteristics, the inner setting, which James defined for us earlier, the place where the evidence-based practice is being implemented, the outer setting, and implementation process. And I'll go through what each of those things means here shortly. So in 2022, Dan Schroeder and colleagues, after the CFIR had been in the literature for over a decade, conducted a review, and they actually sought feedback through surveys from users of the CFIR to make improvements to the model. And so they published an updated version, the CFIR 2.0, in 2022. And so I'll focus on the updated CFIR as I talk about the domains and constructs. Today, the big change to one of the 5 domains was that instead of calling one of the domains intervention characteristics, it's now called innovation characteristics. they also broke down into subdomains, the characteristics of the individuals involved, into roles and specific characteristics of those individuals. So really quickly, characteristics of individuals involved refers to all people involved in the implementation process. The innovation refers to the thing that is being implemented. Inner setting is the structural, political, cultural context of the organization or the place where the thing is being implemented. Outer setting is everything that exists beyond that. So it's often a broader economic, political, or social context. And the implementation process is distinct from the innovation or the thing that's being implemented, but it really focuses on the process of implementation. So this should look familiar. Paul had this on one of his earlier slides, so we're going to go into a little bit more in depth here. So you can see here the outer setting and inner setting, the domains with the constructs that are part of the CFR, the individuals involved, including the roles and characteristics, and implementation process, and that how it impacts here the thing that is being implemented. Right, it's not, so for those online, we lost our screen in the room and it's not coming back on. So give me a second to troubleshoot. There we go. Okay, we're back. Okay, so we'll go through each of the domains and the constructs associated with each. So the first one we'll talk about is characteristics of the individual. And in the new CFR 2.0, there are two subdomains, the roles and characteristics. So here on the left, you can see all the roles of people who may be involved in the implementation process. So from high-level leaders to implementation team members, the innovation deliverers, so the people who are actually implementing the thing. And then another theme from something that Paul talked about is this idea of the innovation recipients as being really important to include in our assessment of context. On the right here is characteristics of the individual. So these refer to individual characteristics. And there's a theory pulled in here to the updated CFR, the COM-B, which includes capability, opportunity, and motivation. And those are thought to influence behavior. So moving on to the innovation characteristics, this refers to the thing that's being implemented. You can see here the constructs listed, things that we talked about earlier, like the evidence base of the innovation, the relative advantage, adaptability, trialability, complexity. So all things to assess when you're looking at things that help and hinder implementation.
Excuse me, the term relative advantage in this case, is that the thing that you're innovating, it's relative advantage over not doing it?
Yeah, to either not doing or what's currently being done.
Typically, it's alternative practice.
Great question. The question was with relative advantage, what is that comparing it to? So typically it's what's currently being practiced or in practice. So next we'll look at the inner setting. So in terms of constructs that showed, there are two slides for inner setting. So this slide that looks at factors that exist in the inner setting regardless of the implementation or the thing that's being implemented. So this refers to structural characteristics, physical infrastructure, IT infrastructure, et cetera, relational connections, communications, and then culture. And some of the feedback that Dan Schroeder got with the original CFR was that culture is fairly ill-defined and often a little bit murky. And so in the updated CFR, there are 4 specific sub-constructs that, that you can assess to inform, that will give you information on determinants related to culture. So human equality and centeredness, recipient centeredness, deliver centeredness, and learning centeredness. So continuing with the inner setting, these are constructs that exist specific to the implementation. So the idea of tension for change, compatibility, so how compatible is the thing that's being implemented with the current context or inner setting. The priority incentive systems, I always like to think of performance management systems in organizations and how those can be leveraged to help change behavior related to implementation. Mission alignment, so this idea of how well the thing that's being implemented aligns with the goals and the values of the organization. Available resources, including funding, space and materials, equipment, and then access to knowledge and information. So again, when we think about inner setting, it really refers to the organization or the place, the school setting, the clinic setting, where the thing is being implemented. And then when we think about outer setting, it's everything beyond that. And there is a lot of interplay between inner setting and outer setting. So sometimes that division can get a little bit challenging. So we'll talk about some of the constructs of the outer setting here. The first is critical incidents. This was found, this construct was added in the CFIR 2.0 and found to be a significant determinant, meaning that it had a significant impact on implementation outcomes. When I say critical incident, I mean that it's a major event that happens that may get in the way of implementation. And I think a recent example is the COVID-19 pandemic. So you can imagine being in the hospital setting, trying to implement an evidence-based practice during COVID in March 2020. It would be a significant hindrance or barrier to implementation of the practice. Other outer setting constructs include local attitudes, conditions, partnerships and connections, policies and laws, financing, and external pressure. Another example that I like to think about with reference to policies and laws has to do with just incentives and how specific policies are implemented. In my work in rural hospital at home care settings, we have patients who receive Medicare and we're trying to keep them out of the hospital in the home. However, when we have a nurse go visit them in home, they have a copay that they have to pay. Whereas if they were to go to the emergency department, they wouldn't have that copay. And so that's a misaligned incentive from a policy perspective that is a barrier to our implementation. And finally, our fifth domain implementation process and the constructs listed here. Teaming is when it can be a significant facilitator of implementation with the right team, a team that's often viewed as collaborative and coordinated, can be a strong facilitator. Other constructs include assessing needs, context, planning, tailoring strategies, engaging both deliverers of the intervention and recipients of the intervention, doing and reflecting and evaluating and adapting the intervention. So we'll take a step back here and talk about the big picture. So those of you who attended our first workshop may remember this logic model. This is the implementation research logic model published by J.D. Smith and colleagues. And you'll notice here the left side of this logic model captures determinants. And if you look at the specific constructs on the side here, these map to the CFIR domains. And basically this logic model allows you, as Paul demonstrated when he presented on the IPARIS, it allows you to link determinants or identify how determinants how they impact implementation outcomes. And further, how you can select specific strategies and identify mechanisms that address the specific contextual factors or determinants related to the setting where you're implementing the evidence-based practice. And so keeping that in mind, there are different ways that you can use the CFIR, and I have to give credit to Kayla Norton for this slide, so thank you, Kayla. You can use the CFIR and conduct an assessment of determinants, again, what helps and hinders implementation prior to implementing the thing. So conducting a pre-implementation assessment, using that to inform a potential adaptation of the intervention. This can also be done concurrently to an implementation, and it can be done after implementation retrospectively as well. So the first thing to think about as you go to use the CFIR is to, one, define your domains. So we had the 5 domains. So what does it mean when you refer to the inner setting? What's the context of the inner setting specifically? What does the outer setting? How would you define that? So another way to think about this is the who, what, when, how, and where. So who are the people and the individuals involved? The what is the evidence-based practice or the thing, and that's important to very clearly define as well. The when and the how refers to the implementation process itself, and the where is both the inner setting and then the outer setting that will influence the process of implementation. Just a few notes on the updated CFR. As Paul alluded to, there are great resources available, and we're happy to share those with you. The website, it's actually not on this slide, but oh, I don't have it on a recent slide. There we go. The CFRguide.org is a great resource, very detailed on each of these domains and constructs with operational definitions and just a ton of resources on how to operationalize this framework. It's encouraged if you already use the CFR for one of your projects to really make it specific to your project. So a lot of the language that's used is broad, and so really think about how you can customize it and use it to meet your specific needs and fit your specific project. And then the final thing I'll add is that, and Paul brought this up, and I think it's really important in this framework as well, is to make sure that the voice of the recipient, the intervention or the innovation recipient is captured, and it's distinct from the person who's delivering the intervention, and both are important. But it's helpful to understand barriers and facilitators from the recipient of the intervention as well. Okay, so we'll move into an example quickly here. I love this example because I think it presents a great method for how to engage key users or strategic partners in identifying barriers and facilitators when you're going to implement a project. And so this is a paper by Knapp et al. And they used a user-driven method for selecting implementation strategies, specifically looking at how to implement pediatric hypertension clinical practice guidelines in a pediatric practice. And you'll notice the focus here is on selecting implementation strategies, but what they did first was they assessed barriers and facilitators to implementation. So this is from their paper, and I pulled the initial 3 steps here. So the first 3 steps that they did were to gather data from key users concerning barriers and facilitators to implementation. They did this through 2 user-centered design workshops, and then they also conducted clinic staff interviews, so very qualitative data collection. The research team developed matrices to identify common threads and contrasts across and within the different constituent group levels. And so basically they looked at barriers and facilitators that they heard from the user group, and they confirmed those findings with they had a stakeholder advisory panel that they convened. And that allowed them to begin with context and then identify implementation strategies that would address each specific contextual factor determinant that they identified. And so step 5 here in their process was to remove overlapping strategies and combine complementary strategies. But what they also did was they defined each barrier and indicated which strategies addressed each barrier. And I'll show an example of how you can do that to show that linkage between determinants and implementation strategies. The other really neat thing they did is that they had the advisory panel score each potential strategy in effectiveness, feasibility, and importance, and that helped to prioritize implementation strategies. And I'm sure we'll talk more about this in our implementation strategies workshop. What they also did was they had participants score each determinant. And so they had each participant score a determinant from a scale of -2 to +2. -2 indicating a strong negative impact on implementation or perceived strong negative impact on implementation, i.e. a strong barrier, to +2, which would have a strong positive impact on implementation, i.e. a strong facilitator. And so that let them see which barriers and facilitators were going to be potentially the most problematic or a strong barrier to implementation, or those that would help.
That too is to make sure we maybe strategies that address all the major barriers. And so I thought with prioritization.
Yes, so for those online who may not have heard JD just chimed in, and you're an author on this paper, I think, JD, right? Yeah. That it allowed them to make sure that they were addressing strong barriers and then also potentially leveraging strong facilitators as well. And so here's the completed IRLM for this project. And I'm going to zoom in again because I'm focusing on kind of the CFR and what's on the left side of the screen here with barriers and facilitators. But what they've done here is that they've actually indicated as they identified these barriers and facilitators, the strength or the perceived impact that these have on implementation outcomes. So the couple that I've selected here, this characteristics of the intervention or the innovation, poor adherence to clinical practice guidelines for pediatric hypertension was viewed as perhaps slightly like negative or neutral on the implementation outcomes. This next one related to the inner setting equipment and clinic structure layout was a strong barrier. And so something that they certainly would want to address when selecting implementation strategies. And then the final one here that I pulled out was with outer setting, we'll say a slight facilitator looking at external quality benchmarks. So being incentivized to make sure that they're complying with these pediatric hypertensive guidelines. The other thing that they did, so in addition to providing a relative weight of each barrier and facilitator, is that they visually are linking the implementation strategies that they selected to the barriers and facilitators. And you can see here they've done that with the superscript letters. And so here for the inner setting, this barrier buy-in from organizational leadership, they have specific implementation strategies that they've selected to address that specific barrier. And again, when we think about the overall process and what Paul walked us through on his slides, this idea that we have these contextual factors or determinants that we've identified, they can inform implementation strategies. We have the mechanisms that we hypothesize contribute to why we think the implementation strategies will be effective, and that leads to the positive implementation outcome. So that is going to be our wrap up before we take a break here. But let's pause and there was one point that I just wanted to highlight, and Paul, feel free to chime in. But I think one of the things that you can see that we've done with the examples that we've presented is the importance of taking these theories, models, and frameworks and really customizing them or making them fit with your project. So they provide their theoretical or logical or just a general framework as an underpinning, but it really is about the specific project, the thing that is being implemented. And so thinking through how you can apply these to your project is an important takeaway. So are there any questions before we take a break here? Yeah.
For the mechanisms, do we have a list of mechanisms that are linked to strategies, or are they being identified through theoretical frameworks or theories that can impact the outcomes in the future?
That's a great question. So the question was with regard to mechanisms, are there theoretical or are there specific theories that we can use for mechanisms? And Paul, I'm going to have you jump in, but I'll give my quick thought on it really quickly, is that this is probably one of the more understudied areas in implementation science, are specific mechanistic theories. For my own work, I typically draw from a lot of behavior change theories as mechanisms. I don't know if there's anything that you want to add.
I think Liz gave a great answer to it. And to me, one of the issues with our theories, models, and frameworks is that we don't show paths very much, right? Like all of the things that we showed you there, it's kind of like, oh, here's this bucket of constructs, and here's this bucket of constructs, and here's this bucket. And sometimes we have some lines that go between things. But, and you know, even I think with using things like the implementation research logic model, which I find super helpful. And we use, I think, almost all of the things since JD published it the first time. But even in some of those, people just put a bucket of things and then one arrow. You have 20 things over here and you have one arrow, then you have strategy, then you have an arrow, and then you have 20 mechanisms, then you have an arrow, and you have an outcome. And you know, that's where I think we're weak in the theories. And so as we go through, and really one of the reasons that I come to the idea of trying to be a little reductionistic initially to say, what's the direct path that I'm looking for this thing, understanding that it's not capturing the whole picture. But we have, you know, from the slide that I showed you guys with each of the things moving along the way, if we can all be trying to test some of these relationships, then we can start to refine the theories. And then they actually become theories, which at this point, I'm not sure that we have a great, well, we have probably way too many of them. We don't have one theory that I think we could say, oh yeah, this is a theory that all of the hypotheses on it have been supported by research. So.
Other questions?
The online.
Let's give the online folks a second. Yeah,
That's a
Kathy.
question along the mechanism lines. So does our research, do we need to be able to demonstrate that the mechanism that we're identifying is what's actually working? To change.
That's a great question. So the question was along the lines of mechanisms, and in our research, do we need to demonstrate that mechanisms are the thing that is responsible for the outcome that we're looking for? And I think, I mean, Paul, I'll toss it to you.
Yeah, I think
Or
it's,
demonstrate that it's not.
yeah, yeah, I
Yeah,
think that
yeah.
it's in, like, I gave a talk a while ago that showed kind of the, over the last 20 years type of work that we've done. And early on, really what we focused on a lot was, do the strategies work, right? Do they change the outcomes? And we weren't really measuring or looking for mechanisms. And one of my good friends and colleagues used to say, oh, you're just a program evaluator. That's all you're doing is program evaluation. And of course, I vehemently disagreed. But having said that, I really think the mechanism piece is where our generalizable knowledge is. Like, why did this particular strategy work within this construct to create the outcome? And understanding how that worked is something that then we can test again in another context and then determine, is that generalizable to that context? And we did. And so I really think, to me, and again, when we talked about fidelity, a lot of times people would distinguish between the form of the intervention and the function of the intervention. And, you know, I'm in the camp that our translational focus should be on the function or the principles that lead to the changes, which is really about mechanisms, right? And so if we don't understand the mechanisms, it's hard for us to really understand the function by which these things are happening.
Can I ask a question? So you are deciding your mechanisms based on the outcome. What if the mechanism changes the outcome? Do you modify the mechanism or would you evaluate the outcome then?
I think if I understand your question, we would anticipate that our strategy leads to a change in the mechanism, which leads to a change in the outcome. If we find that our strategy has a change in the outcome, but not a change in the mechanism, that would make me think that our theory is not very good and we haven't identified the right type of mechanism. If our strategy doesn't change a mechanism, but the mechanism changes and the outcome changes, well, then I think our theory is probably okay, but our strategy isn't very good. And and that's, I think, another really good reason for us to be looking at mechanisms, right? Because that helps us to understand whether the theories are right, and it helps us understand whether our strategies are, you know, just not the right strategies.
I think going back to the question of like, do you have to, or are you expected to be testing strategy or mechanism? It's probably a very much a sometimes question. Often we have like IRLMs that have tons of mechanisms, none of which and it just depends on the scope of the study, whether or not it's measurable, whether it's even a testable thing too, because we often theorize as a way to justify why we pick a strategy. But to Paul's point, you know, even if we're not testing it, being able to say like, I think that this strategy is going to affect reach and not saying why is sometimes really like, not okay for reviewers. So being able to say like, we think it's going to be because of this, even if we're not measuring and testing that as a mechanism, is so pretty relevant.
Yeah, and just in case people didn't hear it from the OWL, JD really highlighted that you can hypothesize the mechanisms, and because of the complexity of this work, oftentimes you're not going to be able to measure and test all the mechanisms. And so again, I kind of go back to the context, strategy, mechanism, outcome mapping and decide what's the primary thing I think we're actually changing. And then I really try and get measures for that primary thing. But we know there's going to be other things. And similarly with our outcomes, you know, like we always say with the, or at least I always say with the REAIM planning and evaluation framework, you should consider all of the REAIM outcomes in your planning. But in your evaluation, oftentimes you're not going to measure all of those things because you don't have the resources, or it's just not the priority of the community, or it's not really going to advance the work that you're doing. But you want to be thinking about all those things on the front end.
If we could go back to culture as a concept, and I'm just looking at the CFR guide here, and I think it may be using culture in a different way. So one of the things that I'm concerned with, just in terms of replicability and things like that, is we insert our intervention in widely divergent real cultures. I mean, cultures like indigenous cultures. And I just don't see this sort of accounting for how, so interventions have to be modified to be respectful of the culture you're applying them. But I'm not sure how best to account for that in an evaluation.
That's a great point. So the question was about culture and whether or not the CFR allows for kind of grasping the full perhaps context of culture and I don't want to say allows for adaptability, but there, you know, this idea of adaptability of an intervention to meet cultural needs. And I think that's a great point. And I think there are, so this is a very like determinant specific example, but I think in terms of that, one of the things to consider is the adaptability of the intervention. And that is one of the characteristics or determinants, either a barrier or facilitation, or how easily is the intervention adapted to meet the specific cultural needs. But it still doesn't get at your point of assessing culture.
I mean, ultimately, so just to give you the example, so we're implementing a grief intervention model for suicide survivors in a culture that does not allow the word death. And so obviously we've adapted. And, you know, glad to do it. We're familiar with the culture, working closely with the interventionists and making sure it's culturally sensitive and allowing time in the intervention for actions that protect people from harm. Well, it's all lovely. Love doing this. Then you loop around and you say, you know, these are my outcomes in this setting. And how can you compare that really across quite different implementation settings?
Yeah.
In a meeting, I mean, I can do it in a narrative, but I think sort of, well, anyway, I'm just interested to hear your thoughts.
Yeah. So I think one of the things that you can do is when you're assessing determinants or the specific context is have, this is again, a very pragmatic answer, but have different CFRs or IRLMs for the specific context. Exactly.
Exactly. And still, you know, when you get momentum of having enough implementation sites, and you want to try it in very different settings.
Right.
But they're very different settings.
Yeah.
I understand the values and the population and the interventionists, that all makes sense in terms of culture. Those are values. More than, shall I say, practicalities of different cultures.
Yeah. And I think doing this assessment in different settings is really important because they're different. And we talked about the recipient as being a key voice in implementing the thing. And so making sure that that is captured for different populations and settings. So an example from my own work is we're, again, going back to the rural hospital at home program, we're working with communities in Price, Utah and Moab. Utah, they're very different communities. And so making sure that we understand the unique context for each of those communities is really important and will inform the implementation strategy selection, the adaptations of the intervention that's being implemented. That sort of
So
thing.
just sort of enjoying the flexibility of it.
Mhm.
The CT.
That's why I love implementation science. Should we go ahead and do a break?
Yeah, maybe
Yeah.
10 minutes.
15? Is that what you said?
Let's do 10.
10, okay, perfect. Let's take a 10-minute break. So we'll come back at, say 10:45.
Okay, do we have folks online you can hear okay? And okay, fantastic. So in the room here, you guys will get a chance to introduce yourselves to one another in a moment. So we'll maybe get the attention back up here. I'm having poor classroom management at this moment. Okay, I think I got everybody back now. So the next part of the session today that we're thinking will probably take somewhere between 45 minutes and an hour is we're going to go through 4 different examples where I'm going to provide you a contextual factor and an outcome. I'm going to describe to you at a very high level a project that we've done, and you're to identify what you think would be a primary strategy that we used and the mechanisms by which that strategy would achieve the outcome. Okay, so to give you a little more clarity on that, I'm going to start with telling you, remember we talked about Weigh and Win. This was a weight loss program that was developed for both workplaces and communities. We're going to focus on the workplace version here. And so with this intervention, we packaged behavioral intervention to support healthy eating, physical activity, self-regulation to achieve healthy weight loss for employees. Okay, all available online, either via an app or someone could do it on the computer. They could just use a web interface. Those were the 2 ways that it was packaged up, and it was delivered to people with daily either text or email messages that rotated through social cognitive theory concepts to promote behavior change. Okay, so that's all packaged together. So that's one strategy that we used. The next one was we had external support or external facilitation, we might call it, where we actually worked with the workplace to get all of the technology integrated into their system. They didn't have to do much of that. Anything took very little time for us to be able to plug in and allow the intervention to be used by the employees. We made environmental changes with what we call the health spot, where in a private area, people could go, they could stand on this weigh scale. The weigh scale, they could, they typed in their login, it took a picture of them, took their weight, and then that picture was sent to their motivation center so they could see progress in weight loss over time. It also then kicked back to an overall data repository that the worksite could monitor and manage how people were doing. Or they could just leave it and let the thing run. And then the last thing we had was we had modest financial incentives based on behavioral economics to nudge people from more preferred, less healthy behaviors to less preferred, more healthy behaviors for a short period of time until intrinsic motivation kicked in and they began to do the behaviors just for the intrinsic motivation that they realized from those things. Even though we tied this incentive to weight loss, the intent of the incentive was to increase reach. So its whole goal was to be able to say in a workplace, get paid to lose weight. So that was one of the hooks. Okay. That's the intervention. We rolled it out across 28 work sites in a cluster RCT. And I think that's about as much as you need to know about it. I'll be circulating and you can ask questions about things, but I've pretty much given you all the information you really need. And we're going to do this both in person here. For the online folks, we're going to separate you into two groups. And one of our great health and kinesiology doctoral students will facilitate the group, and you guys will do the same thing. And so I think I'll just let you guys walk them through the Miro board and all that kind of stuff. Okay, so I'm going to move it along here now. So then what I want us to do, this is how it's going to look for you. You've got a set of cards. Those cards have context, strategy, mechanism, and outcome labels. The context and mechanisms are drawn from the PRISM, the pragmatic, robust implementation and sustainability model. And then the strategies are pulled from the ERIC strategies, although we reduced a bit so that we didn't have to have 73 cards for you to sort through. And then the outcomes are based on REAM outcomes. You'll find a few blank cards that if you were really crazy and you wanted to write something on them, you could go ahead and do that. But, oh, how do I get rid of that thing that's, oh, there it is.
Just exit.
Let's see. There. It disappears as simply as that. Ah,
Weird.
okay. Dang it.
Let's see if we can move that.
Let's just see it quick.
We don't see it online.
Yeah.
You guys don't see it on its own. Well,
No.
it's great for these guys. We're getting the pro in now. Oh, yes.
Just, I'll move it over. Is that okay? if
Yeah,
it's
that's
there.
perfect.
Okay.
And we'll just re-engage
Oh,
this.
you know what, but Zoom
What's that?
is we're looking at the Miro board.
Yeah,
Is that okay?
that's okay right now, but
Okay.
I think
Oh,
so.
there we go, there we go.
Now,
That's-
the people online, do you see the slides too? Okay, so what you're gonna do, so the first thing, context that I want you guys to find in your context cards is human resources. We did this study in small to medium-sized workplaces, which means that there were constraints around personnel that could actually engage in doing health promotion for their employees. Okay, so that's the context. We have to fit a strategy into a context whereby there's just not a lot of human resources to be the recipient implementers. Okay, so we want you to search through the strategy cards, and I want you to find a primary strategy. So you're going to find a lot of them, but you've heard a little bit about the things that we've done. I want you to find a primary strategy and then search through the mechanisms. We identified 3 mechanisms for this. You guys could identify more. And you're going to put this together, and we're going to have a little race and see who is the first group that completes the activity. Okay, we're going to do one of these for adoption, one for implementation, one for maintenance, and one for reach. Okay, so we're going to try and get through these. Is everyone clear? Who feels confused?
You learn the rules as you play.
That's right. You learn the rules.
You learn really by.
We'll wander around and help you get started. And go. Okay, folks, maybe we'll bring the groups back up to the front. So let's do a very quick, we're gonna roll from each group, and I want you to tell me the primary implementation strategy that you identified. Because I know that some groups identified multiple, but I want what you think is your best strategy. Okay, let's start here.
Engage organizational champions and leaders who can communicate the program and expectation to the participants.
Anyone else have that one? Okay, so we got 2 groups with that one. Okay, strong.
That's
Now-
not our primary.
What's your primary one?
Create and communicate the relative advantage of using this program.
Okay, create and communicate the relative advantage of using the program. All right, Barry back.
Automate all part of the program.
Okay, anybody else have that one? Okay, so we have 2 groups with automate all or part of the program. Okay, so let's do the all or part of the program. Give me 2 mechanisms you identified. This group,
One,
yes,
okay, we had implementer capacity Feasibility, acceptability.
Okay, you gave me three.
Yeah.
Look at that, look at that. That's pretty good though.
I'm so used to feasibility,
Yeah.
acceptability together. It just
So good. Okay, how about the fellas at the back? Organizational capacity and feasibility and access. Okay, I like those ones. Okay, so for your groups, for your primary strategy, what was the mechanism?
So if we're giving two, we group kind of together organizational decision maker beliefs as well as their motivations.
Okay, great. So organizational decision maker beliefs and motivation. How about for you guys for your primary?
The vision, evidence is information complexity, and we have mental capacity and organizational readiness.
Okay.
Question with that, wouldn't you, if you were gonna implement this, wouldn't you have already fully automated it before you even approached HR?
Well, remember, what's our outcome that we're trying to get to? Adoption. Get them to make the decision and initiate delivery of the intervention.
Don't
So,
forget, this is not HR.
I mean, you said,
This is humans in the organization.
but like if this is a little bitty organization.
Yeah.
You couldn't say, here's the idea, and then if you like it, then we'll fully automate it. You'd have to do that first.
correct, yeah. And this is fully automated. Before it got to the work sites, it was fully automated.
So what was the first,
That was the strategy. So I'm gonna go ahead and show what we did in our project. Maybe I can get it to move forward. There we go. So that was a strategy to automate all of the program so that there wasn't the need for a lot of human resource support. Okay. Then what did we have? The made it compatible with that context, right? Since there's not a lot of human resource need to deliver it, that makes it more compatible with that particular employment structure. The innovation, it has a relative advantage because it's relatively easy to put in place, which is the same as the third one, which is complexity, right? It reduces the complexity. We just have someone external needs to meet with one person internal and it gets set up and everything's automated from there. So and we think that's very attractive to workplaces. So we think that will influence their adoption decision and uptake the intervention. Okay, a couple of sticking points I heard. One was about language. And, with this type of activity, it's always like, well, who's delivering? And so with this one, that was a hard one for me to answer because it's like, well, no one's delivering. We have a facilitation that gets it in place and then it's automated and it goes. Now, in the 28 work sites that we have, was there somebody that facilitated in every work site? Internally, yes, there definitely was. But were they part of the human resource infrastructure? Typically, they were not, because most of the workplaces did not have that type of infrastructure, but they had a wellness committee or they had that kind of thing, and people on those would move forward. What were other kind of sticking points?
It wasn't clear to us what was meant by organizational,
Okay.
right? Because you could consider organizational the top down, you could consider organizational the HR, you could consider organizational the champions that you have within a department.
Yeah.
So that was kind of.
So even just kind of the multi-level nature of some of our constructs and even some of the concepts and I think this is very true of some of the context cards that we have. It's very true of some of the strategy cards. They're pretty general, right? Like you don't really exactly know what it means. And so as we go through this, the intent of the activity is to start you thinking through, well, what's that action? What's the strategy that we're trying to fit within this context that will change this outcome? And then we want to think through, okay, well, if it's going to do that, why is it working? What's the primary things it goes through? So this time we're going to move on to the next one. The next one, we're going to look at implementation. So remember, this is delivery of the intervention. And so you might think about this one in terms of, well, what is delivery of a primarily automated intervention? So implementation in this case is likely about how that system's put in place and in a way that can be delivered as it was intended to be delivered. This one is a little bit trickier with this type of intervention. So think about Oh, the context we're gonna have here, it's a very similar context to the last one. We have the people that are doing the implementation, so I might consider someone in the workplace is helping to move things along with employees as they go through this automated process. So that's the addition I would add here. Okay, so that there's somebody in the workplace that is helping folks move things along, but those folks have a lot of competing demands.
And is that person in leadership? Is that person?
They could be, because of the size of the workplace, it could be somebody that is in a leadership position. It could be someone that is, as I said, there may be a member of the wellness committee that is something people do on the side of their job, but because they're passionate about it, the champion kind of idea type of thing. So it could be anybody, but it's somebody that's helping to move along so that we make sure that people are using that waste scale. People are, all that kind of stuff around how we'd implement it.
But the organization is bought into it.
Yes, they now have it, and
Now it's
yes,
the process.
that's right. And so your context is you have implementer competing demands, and we're trying to figure out implementation quality. Okay.
This is that.
And think about things like, what if the system went down? What if, there was tech problems, those types of things.
But this is a fun activity.
Okay, great. I think, let's do the same as we did last time. Very quickly, we'll start around this way this time. What did you have as your primary strategy? This group, the folks right here.
Oh, the middle ones? I'm
Yeah.
sorry, we're talking too much. Primary strategy to provide training, technical assistance, and other support to staff.
Okay, training, technical assistance, and other support. Excellent. Mechanism, give me your mechanism. Or
We
two.
have anything related to the implementer, whether developing capacity, self-efficacy, knowledge, and motivation.
Okay, great. You guys, primary strategy?
Same.
Yeah,
see how our what we're doing strategy.
I think they finished about 10 minutes before you guys, so I don't know if it's really that direction.
Any technical assistance and other support.
Okay, and then what was your mechanism?
We have implemented capacity.
Yep, implementer capacity, okay, good. Okay, Toby, your group? Okay, read, sorry, I missed the first part.
Leadership and others for ongoing support.
Engage leadership, and others for ongoing support. Sorry, I should have these memorized, but I don't. All right, last table. Oh, your mechanism, thank you. Toby, what's primary mechanisms?
Support, capacity, feasibility.
Okay, management, support, capacity, feasibility. All right, and the CCET table?
Plus. Implementation blueprint.
Oh, a packaged implementation blueprint. Okay, I like it. And your mechanism?
All of those implementer things, self-efficacy, capacity, knowledge, and motivation.
Okay.
One without the other.
Yeah.
Okay, you got a good bundle there. Let's hear from the online group. How did that? Let's hear from the online group. What was the primary strategy?
A little slow getting these up. I think one of the key ones that we identified was expert facilitation. The assumption the implementer was the expert.
Okay, expert facilitation. And what was the mechanism? Or mechanism?
Implementer capacity, self-efficacy, motivation.
Okay, a lot of the same mechanisms, even though you guys took some of the different strategies, which is not wrong, right? Because a lot of times we could have multiple strategies that would work through the same mechanisms. So that's really fairly straightforward. Here's what we had, expert facilitation. And I would say that if you remember right from the beginning, one of our strategies was external facilitation. So if the thing broke down, it was our team that would fix it, right? So it was expert facilitation to get it back up and running. And so that was the way that we built it. This one, again, we reduced the complexity for the workplace because they didn't have to address it. and we make it more compatible with the level of competing demands that folks have that are trying to help move this along. Okay. Great. Let's see, we've got. Do you guys want to do the maintenance and the reach one, or do you have a preference for one or the other? One or the other, okay. And why don't we go to reach? Because I think it's a little different from the others. So for the maintenance one, if you guys remember, I'll just walk you through this one. We had the available data from the health spot. And so with that, we could use audit and feedback to make sure that the beneficiaries were ultimately engaging in that, but then we could report back and show the management that the intervention worked, and it increases the observability of the intervention, which leads to a higher likelihood of maintenance of that intervention being delivered in the organization. Okay. All right. So now we're going to do reach. This one, the beneficiaries, the question I got asked before is, who is that? That's the employees that are engaging with the weight loss program. And so what we want to know is, what strategy did we use to increase reach? I feel like I gave this one away right at the very beginning, but I'm going to let you guys roll with it. What were your primary strategy and mechanisms?
Strategy, adaptive program activities, including priorities, preferences, culture, and demographic, historical and other factors.
Okay, so in short, they picked adaptation based on culture, characteristics of the recipients, right? And your mechanisms?
Beneficiary motivation, acceptability, feasibility.
Okay, great. Feasibility, accessibility. What was the first one?
Beneficiary motivation.
Okay, increased motivation, beneficiary motivation. Great.
To
Thank you.
understand it.
Yeah,
Difficult.
great. Okay, let's go to you guys next.
Yeah, just like addressing some social determinants of health also, using incentives and
Okay,
to increase reach
so incentives was
and policies.
and policy support.
That's right.
Okay, great. And a mechanism?
Primary, I guess, would be motivation, belief, and acceptability.
Okay, so theirs would be beneficiary motivation, beliefs, and acceptability. Okay, you guys?
Are you asking us?
Yeah, Rebecca,
You
you're,
said the
okay,
same for the first group, so adaptation.
okay,
For the group that we're trying to reach, and
okay,
then we take access, acceptability, and beneficiary.
okay, we're getting some consistency around mechanisms for sure. Kayla, what did we get on the, or whoever?
We had, oh gosh, okay. Reducing barriers or using accessing the program. So like lower complexity, high cost.
Okay.
Or cost, and then mechanisms, beneficiary motivation, access and benefits.
Okay, so reducing complexity and then similarly beneficiary outcomes or perceptions, characteristics is the mechanisms, not the characteristics, that's what the context is. Okay, James, did you have time to reduce it down to give us a primary strategy?
Multiple pathways. So we talked about first, adapting the program to fit the priorities, culture, workforce, and that would work through appropriateness and acceptability. But then we also have another strategy, use incentives and policy supports. If it's really more about accessing the app, having a phone, having that resource. They thought you could also fund a contract for those kinds of things, but really similar, providing access, beneficiary capacity to get to reach.
Yeah, James's group had a ton of ideas. Which I think, you know, and honestly, I'm going to show you what our primary was on this, and we talked a little bit about it. The incentives and policy supports, the mechanisms, the acceptability of the intervention. So improve that an employee thinks, oh, I like this. This feels acceptable to me. And that it's better than other programs because they're going to pay me to lose weight. So it's really those two primary mechanisms. One of the things that you might feel like there's a bit of a disconnect between the characteristics of the recipients, where I feel like folks appropriately thought about characteristics that would be related to disparities in weight and weight outcomes. And in fact, what we didn't talk about today, and I'm sure we're going to get to in one of our future workshops, is how we do co-creation of strategies. And so this incentive approach was developed in partnership primarily with African American participants in Virginia. And in fact, our incentive approach increased the representation of Black employees over and above other employees. And in fact, the intervention also worked better for that population. So it ended up being a really nice study where we were able to demonstrate that we were actually reducing disparities through the engagement and the use of this type of strategy. Now, the strategy wasn't why it worked better. The intervention itself was good, and we're not really sure why it worked better. And in fact, the one that you guys, many of you chose, the adaptation, is where we're currently at with that community. And we have an R01 that we've just written up to compare the original to an adapted version that's intended to improve adoption reach, but also effectiveness. And so hopefully this was a fun activity for you guys. We wanted to bring it out just so that you get a little bit of interaction between different theoretical concepts as we're going through in the types of things that we often do with our partners, right? We want to increase the reach of this great thing that we have. How do we do that? And so we start to talk through this type of approach. Alistair at the back asked me, would I do this with communities? We haven't done the cards with communities, but I'm sure many of you have done, like, we call it causal mapping. Other people, there's, kind of the group model building types of things. We would go into community and we just talk about, well, what do we want? What's the outcome we want? And then what are the assets we have in our community that could be applied towards that? What are the barriers that are going to get in the way of it? And then how do we combine these things together to come up with strategies that will actually lead to the outcome? And so you might not do, like, I think, as you guys could see, and I mean, we heard the question about language too. This type of card thing, I don't think the wording and the language on them is really very accessible, but it's really intended for you guys just to get a sense of, hey, there's a lot of concepts out there, and anything that was on a context card or a mechanism card is coming from the theoretical approach that we had. And so and hopefully you found those things helpful, because it helps you to start to think through what fits here and then how's it going to work. So, okay. Our big wrap up here, we had some time for, hopefully we'll have a little time for questions still too, but we wanted to get through this. Art, do you want to run through the final slides or? Okay.
Yeah, maybe quickly, and then we can just have open discussion.
Okay. Well, I think I've said the first bullet points up here. Hopefully the take home that you get from this is that theories, models, and frameworks, and primarily what we've talked about today are explanatory or more kind of classical types of theories. They can really help you understand the context within which you're going to try and get an evidence-based intervention adopted, implemented, and sustained. And it can also really help to understand the mechanism by which the strategies work. And then, if you understand the mechanisms, it really opens up the world to strategies, because there can be a lot of different strategies to hit a specific mechanism that might work across a lot of different types of contexts. The assessment of the context and mechanisms, we talked about this a little bit earlier. You're not going to be able to measure all contextual mechanistic factors in any of our theories in any given one study. Even, I talked about how we like IPARIS because it had the ORCA instrument that we've used a lot. But even in that study, we use that. And then we pull in some other measures because there's other things that we feel like we need to do. And in fact, a lot of times when we work with partners, there's components of those measures that the partners just aren't that interested in. And so it's important for us to try and get measures out there, but I want to highlight, and we'll get to again, how we would apply quantitative and qualitative methods to these types of approaches. And I really think that there's a lot of opportunity for us to use qualitative methodologies to get a better handle on mechanisms and not have to hang our hats on, oh, we need all these surveys from all these providers and all these participants, which ends up being really burdensome. And in my view, oftentimes also changes the relationships between the very constructs that we're trying to assess. And then the last point I would say, and hopefully you got the sense of this, we've had NIH grants where we've used IPARIS, we've had NIH grants where we've used CFR, we've had them where we've used EPIS, we've had them where we've used basically in our group, I think we've used 5 different theories across projects. And the theories that we used, we selected based upon partner needs, project, and the focus that we wanted to go through, to follow through on. So scientifically, it doesn't really matter what theory, model, or framework you choose, but the practicality of it really matters. So in your selection process, really considering what the outcome is that you want. If it's more dissemination related, you're probably going to pick a theory that has things that are more about social networks and how things might spread through social networks than you are a theory that focuses primarily on resources to increase implementation fidelity. And then again, the phrase, pick the theory, model, or framework that the concepts and constructs resonate with you, your project, and your partners. And if you do that, you're going to pick the right. All right. Liz is going to take us, Liz is going to wrap up. And then if we have time, we'll take some questions. I think we have lunch somewhere too.
We do. Yes, thanks. Okay, so before we open it up for question and answer and just general discussion, there's a few more housekeeping items as we wrap up. I had a couple of offline conversations with folks. We, as the Dissemination and Implementation Science Core, as part of the CTSI, offer consultation. You can see the services that we provide here. So if you're interested or have questions about your specific projects, we are more than happy to meet with you. So please feel free to reach out. We have, if you submit a request form through the CTSI's website, that comes to us and we'll follow up with an email and set up a time to meet. So just want to make you all aware that this is here for reference or as a resource to you. We also offer the graduate certificate in implementation science. So you can see here the credits and required courses for that, and more information available online as well. And then finally, there's a wonderful training program offered through the Mountain States Partnership for Community Engaged Dissemination and Implementation Science, or MSSETI. It's a year-long mentored program that kicks off with an in-person intensive with didactic content, and then year-long mentorship where you're paired with a mentor for your project. And then finally, before I open it up for question and answer, thank you for attending today. There is lunch and there's plenty of lunch. So please feel free, even if you have to run, grab something on your way out. It's just in the cafeteria across, or the room across the hall here on the left side. And then if you have a few minutes to fill out an evaluation form, we would love your feedback on how we can make these workshops better. We also ask for any ideas that you have based on needs for your projects. Please feel free to send those in. We're hoping to continue these workshops over the years. So we're launching with the 3 inaugural workshops this year, and then we'll continue next year. One final note, I will send out the slides and a link to the recording as well as this evaluation form sometime within the next week or two, just depending on how long it takes to get all those things together, but be on the lookout for that. And if you have any questions, of course, follow up with us and we're happy to answer those. So with that, thank you again for attending. Are there any questions as we wrap up?
So when it comes to getting feedback from the community partners, would you suggest going to them with the problem that we have identified and getting their feedback on those, and then coming back to your office, thinking about what you have heard, and then map them onto the TMFs and the theories and strategies? Or would you go to them with some theories, introduce them to these theories and the strategies, and have them rank them?
That's a really good question. And so I think one of the things that I talk a lot about with our folks as we're trying to develop new projects is that if I have something like an evidence-based intervention that I think is great, and I know there's a gap or an issue, what I try and do is identify organizations or service providers that have prioritized that already, so that you're coming there with something that may be of value to them. But, you know, I typically, you know, so that's one method. Another method could be that you have a specific population that you're interested in and more health generally, then going through engagement processes where collaboratively you come up with priorities. That's usually not something where you have a specific agenda that you're bringing in outside of just wanting to try and help with the health of that community. In those cases, you'd come up with something together. In terms, the other thing that's kind of, I think, a really important question is like, how do you choose a theory with the community? And I would say that the way that I've done it, and I don't know if it's right, but the way that I've typically done it is we go in and we have a process that, as I talked with you before, about kind of concept mapping and what's the important things, what do we think we need to do to fill these gaps, why do we think it's going to work? I would take that information and I'd probably go back and say, oh, they're talking a lot about facilitation, you know, and they're really, I think that maybe IPARIS might be the best thing for this. Or they're talking about a lot of process strategy that aligns nicely with CFR. So I might bring that back. But when I say bring that back, I would cluster the information together and usually talk back and report back, make sure I got everything right. And I might even say, oh, and you know, we're going to use this theory that really aligns nicely with this. But I would not go through the theory. I wouldn't go, like, I feel like a lot of times that loses energy in the room and they start to think that you're there just for the science and not necessarily there to help them with whatever the issue is. Sorry, that's a long answer.
I do think, though, that we're continually going back and forth with your community on first identifying the problem, identifying the contextual factors, collapsing those into, we can use an IRLM and bringing that back to them and say, are these truly what you think are the biggest barriers? We are going to implement this. Then kind of moving through it, like we did this, what's the context? What's the outcome you're trying to achieve? And then starting to co-develop those strategies and not making them do too much work, but also really making sure that they have a very clear idea of what those strategies are, how they would actually enact those, and if they're actually feasible. So really going back and forth at multiple steps, I think it's a really good.
And just with the outcomes too, that like, you would think all of the outcomes are important. And do you do all the outcomes? Do you make strategies and mechanisms for all the outcomes, or do you choose at this phase, which is focusing on this outcome? And how do you determine that?
I would say that typically we don't do all of the outcomes. I'll give you an example. One of the very first studies I did a lot of years ago with Cooperative Extension in Kansas, they wanted to have physical activity programming for rural communities. And so we collaboratively developed an intervention together, and where they were kind of interested in effectiveness. They kind of relied on the fact that we had evidence-based approaches to be able to change behavior. So they almost took that for granted. And what they really wanted was that they were evaluated by, and their funding structure was based on reach and how many interactions they had. And so for that community partner, we assessed effectiveness and maintenance. We reported that back to the partner, but what they wanted most was we created impact statements for them that talked about the number of people and the types of folks that they had and regionally where they came from. And so reach ended up being the primary outcome there. And again, we still collected effectiveness and maintenance, and we monitored adoption. And in fact, adoption, we tied very nicely in year 2 of adoption was the main reason people picked it up in the second year. And 50% of the counties in Kansas picked it up the first year. Second year, it was up to almost 80%, and it was entirely because they saw the reach of the program in other communities. And so, you know, we tracked adoption, we reported on adoption, we tracked sustainability, maintenance of the program. We didn't track implementation. And again, this was like 20 years ago, and you know, that just wasn't it wasn't of that much of interest to them. And frankly, at my point in my career, I was still at the point where it's like, let's get an activity program that reaches a lot of people and works. And that's what we value. Yeah, there are examples of when you put a single outcome that might not have been what scientifically we would have.
Oh, not scientifically, I was
Or
doing.
business channel.
Yeah, I mean, my initial thought was the main outcome that you think needs to be aligned. So what is the main problem? And I always use the Gagley of Shoup and Glasgow figure that shows like the first issue is just getting it adopted. You get it adopted, then you need to focus on reach, you need to focus on fidelity of delivery, et cetera. So in a situation that someone's already adopted, but there's further outcomes of garbage, it's actually not an adoption problem. So like then it makes sense. Then you have to dissect and figure out, is it an issue of we're not reaching people? Is it because nobody's actually delivering it? It's because when they do deliver it, it's more fidelity. So then you start to focus on, okay, it's a fidelity issue. So like fidelity strategy, fidelity is a primary outcome. And you could, I think, reasonably posit that if you can improve fidelity, you're going to also improve effectiveness, so you can also improve reach, so that they're all interconnected. But yeah, making the scientific case, and I totally agree with Paul, that we have absolutely measured outcomes for the partner to make sure that they're getting what they want. Sometimes those are not even included in the research strategy. Like they're just things you do. But you know, scientifically, it's a different.
I will say though, that if you don't measure what your community cares about,
Yeah.
they're just not gonna be engaged. You have to, it has to be what they want. I was thinking of your weight program and the scale. And you know, I was referring to the Navajo Nation who grocery shops at the gas station. And so when you said we need multiple strategies, you're right. Because in a food desert, that's not gonna make a difference.
Yeah, absolutely.
So, you know, they're just the context of the layers and the layers of the context, really.
Yeah, that's a really good point, because when we did the adaptation for weighing for the African American community in Omaha, that you know one of the strategies that came out from the group was that because we were also in a food desert, even though it's you know in the middle of Omaha, in the area that we were working with, and a lot of social needs, but the community didn't want direct like you know hey. Do this or do, and so in a lot of our messages, we changed messaging around like, hey, no more empty pots. Here is a recipe for no more empty pots. And then if someone wanted to click a link or if they wanted to call a number, you know, and again, we have kind of web-based that's a little bit easier to access for people that have smartphones and that kind of thing. But it was, yeah, they want other components that can address other contextual factors to help things be.
Seeing with your model, just the fact that you emphasize privacy of where the machine is. I mean, the number one reason people refuse to have their weight taken at the doctor's office is the scales. So, I mean, they're just things like that, that it's the dialogue you're having with your community. Wouldn't put it in the lobby of the bank.
Yeah. In our community one, the most used places were furniture stores and libraries.
RC really right next to the free hot dogs, right?
Yeah.
This was great. Thank you so much.
Yeah, thanks very much.